magicianship. My name's Lisa Keefauver, and I have the honor of moderating today's conversation. Thanks to Suzanne for inviting me to do that, and really for the Livestrong Foundation for having these important explorations and these important conversations. I wanted to orient us a little bit briefly about me and sort of why I was passionate about being the moderator for this session, and then open it up to have, I hope, as Suzanne said, this isn't a talk by me, this is a working session so that we can help move this conversation forward to some more crystallized action plans. As she mentioned, I am the founder of Reimaging Grief, and I'm passionate about changing narratives around grief, but also changing the narratives more globally around wellness, including mental, psychological, emotional wellness. This topic in particular, renaming mental health, is particularly appeals to me because I spent a career as a social worker, as a narrative therapist, and I'm also a widow. I lost my husband 10 years ago to brain cancer. And so I've been a navigator in the cancer care system. Based on the conversation from the ICON series earlier this year, a group of experts like you, maybe even some of you were in those conversations, helped to uncover the significant barriers that cancer patients and their families face when accessing what we traditionally call mental health services as they navigate cancer care. So as a moderator, I'm gonna use my moderating opportunity to throw in my 2 cents for the conversation at the top to maybe hopefully set the stage or the framework for this conversation. You're welcome to take what you like and leave the rest, as they say, but I think it's important when we think about this practice, again, as someone who trained in narrative therapy, I understand wholeheartedly that language matters. Language in itself isn't the only thing, though. We have to understand the power of narrative and how it sits in our broader culture. And I know we're talking to people from all over the world. So whether, US culture has a particular flavor, but wherever you are in the world, we have particular beliefs that make mental health have a lot of baggage, and also means that baggage interrupts our access to care, both our own willingness to access care, but also what care is provided to us. So for starters, it implies, one of my issues with the name is that it implies this false assumption that our cognitive, psychological, emotional selves are somehow detached from our physical being. So when we name it and label it as mental health, it's as if we are experiencing something from here up, and completely ignores the absolute science that, of course, we are whole person beings. Culturally, mental health has been sort of attached to a sign of weakness, which sort of counters our cultural, here in the US anyways, and in many countries around the world, sort of pull yourself up by your bootstraps mentality. And so mental health kind of conflicts with that sort of cultural narrative. Then our family systems probably inherited a lot of those cultural beliefs. So we may learn in our family systems that you don't ask for help, you don't talk about your problems with other people. So those cultural baggage tags that get attached to that mental health label kind of filter down to our families. That can be a barrier for our care. I also want to just name that I think we've historically, medical systems, culturally and otherwise, have pathologized very normal responses to pain and trauma and fear. And so, which just creates further isolation that we already experience. And I, of course, because of the place that I sit, feel we do that especially with grief, and the fact that we actually ignore grief as very prevalent as a mental health issue in cancer care, anticipatory and other kinds. So while there are real significant, sometimes pre-existing mental health, what is traditionally labeled mental health issues for patients and their families before cancer and before cancer diagnosis, I want to invite us all to help reshape this narrative so that we don't ignore this sort of and further pathologize, again, people's really normal, natural responses to a very scary, for instance, cancer diagnosis. So for me, I want us to consider today the name, which is what we're here to do, but I would love to invite you to consider it in a broader context, because the value of changing a name is not going to have an impact. It actually is kind of what Michael was talking about before, with this digital nutrition. Just having the name is not enough. if we don't actually have the policies in place to enforce it, if the medical providers and other care providers and institutions don't actually believe in the value of this reimagined mental health label, and if the institution itself isn't set up there. So those things all have to happen in concert for us to break down these barriers. Okay, well, that was my 2 cents. You're welcome to take it or leave it, add to it, or throw it away. So I want to just invite you and open this conversation up to maybe start with, and we're going to do a hand raise. Suzanne's going to keep an eye on all the screens so we make sure we're not missing people. A virtual hand raise, whatever that little hand sign is. To what made you show up for this particular conversation? So what about the name mental health strikes you as a barrier, either to patients or families accessing support? And if you want to sort of come in with a sort of name suggestion or change, that would be a great place to start. I have some other prompts, but maybe we'll just start there with what's driving you to this conversation today, and what would you like to see? Suzanne, I saw Kwana, but I can't see all the screens, so. You're on mute.
Unmute myself and then I can call on people. Sorry about that. If you can use your little digital hand, if you guys know how to do that, because there are so many of you, which is wonderful. There are 20 of you. Kwana, go ahead.
And my name's Kiana. Just
I'm sorry,
Kiana.
Okay.
I know nobody ever gets that wrong, right? Sorry.
I use Keanu Reeves as a good way to Kiana. I met him in the 90s, so there's a way to remember.
Kiana. I got it now.
Thank you. I would say one thing that made me want to show up for this conversation is that as a cancer previvor who went through prophylactic treatments and nearly died after one of my complications, mental health and having the trauma and fear and depression, anxiety, and PTSD happen, none of my providers gave me support for that. And part of that, I believe, is impacted by unconscious bias in terms of women not being believed nearly as much in regards to pain, physical and emotional, and due to different racial biases. And so when I come to this conversation, I'm very passionate because I think about how many people are not given support at all, not told any options. When comparing my experience with other women that I knew at the same time going through similar procedures, we had like night and day experiences of even learning about mental health resources, or having the stigmas really play a role. And so I'm passionate to think about how do we reframe this in a more holistic, integrated way. And so that's why I'm showing up, and I'm looking forward just to being supported and supporting others with whatever we come up with today, and learning more about what can we do to continue to move this conversation forward into actions.
Yeah. Kiana, thank you for sharing that. And I love that you brought up, thank you for sharing. And I just want to look you in the eye, if I can find you on the screen, and say, I'm sorry that happened to you. And I wish that was an unusual circumstance, but I actually think it's frankly all too usual. I mean, I can imagine many of us are here. We had a similar experience in my case with my husband. I like that you use the word integrated. It goes back to what I was talking about before, that when we set up systems of care, doctors, not just to pick on doctors, but nurses, everybody are trained to look at people at their elbows or their hearts or their lungs or their knees, and not to really look at the sort of whole person. So I think something around that name, that language around integrated, could be a really great place to start. And I know some organizations are doing it, so we're not maybe the first to do it.
Michael.
Yeah, thanks. The reason why I think this effort or pursuit is so challenging is that, I'm only drawing an example from here at the Institute. There's a vibrant debate, even almost one sometimes bordering on violent, about what is the proper vernacular to pursue new economic models, and that's in economics. It has nothing to do with health. And the place stopper for the moment is regenerative economic models, not degrowth. That's also part of sort of leftist literature. But in the American healthcare landscape, and I'll just give you two examples, Dr. Carrie Barron, who divides her time between U of T Austin at the Dell Medical School and Columbia, specializes or leads a lab in Texas called the Center for Creative Resiliency. That's a nice term. It's not clear that it encompasses all of the different challenges in mental health. The term that we use, and again, I don't think this is a perfect term either, is emotional resilience. It's difficult to build emotional resilience. Behavioral health is also an admittedly imperfect term. And I think it also varies from case to case. And I'll give you two in particular that I find enormously problematic. When we were starting to have stakeholder interviews with men and women in the Air Force, the people that seemed as though they were well positioned to endure hardship when they were deployed in place, which means they're fighting wars every day from 9 a.m. to 5 p.m. and 30 minutes after leaving the base, they're shopping for food at Ralph's. And that's creating massive issues in terms of cognitive dissonance. But the people that were doing better had a religious practice. They were mostly Christian. I mean, you can see by my face, I'm something else. This is about as Jewish as Tevye. But they were better positioned. If they had a family, they were better positioned. If they had a pet, they were better positioned. And if they had a role, that was what they had expected when they first signed up. If they had none of those things, the likelihood of them experiencing anxiety was dramatically higher. From anxiety going into that perilous slope into depression, higher. And from depression to PTSD, which becomes immensely difficult to treat, there was almost no stopgap. And so I guess the question I have is, the Air Force is one example. A second is that they don't have a culture that even supports the voluntary admission of struggle, because you will have your security credentials revoked. If we think about the civilian or just American civilians, it's all fine and well to talk about mental health in the office place and hope to have open-hearted conversations. But if somebody has a hypomanic episode, meaning just below mania, who do you call? Your healthcare provider? How do you address the issue as a team in an office place? It's all fine and well to talk about these things in the abstract, but when they actually descend on your plate or into your cubicle or into your home, it's really hard to seek the care that you need. So I guess my question, not an answer, my question is, given the other vibrant debates in America at the moment about gender pronouns, about racial terminology, about everything, do we think that tackling this how do we want to, like the linguistic dimensions of illness intervention is the best path forward, or is there a more circuitous route to reaching the same destination? It's just a question.
Yeah, I really appreciate that question. And that's sort of, I hope, what I was communicating at the top of this kind of conversation, which is names are great, but if we don't actually make accessible and practicable policies and procedures around care and offering and receiving, and make it in the hearts and minds of the people who are there to offer it, and also maybe expand who is offering. You brought up spiritual, for instance, or family systems as being useful supports for people's whole centered well-being. Whether or not we change the name mental health as it relates to cancer care, are we open to making sure providers prescribe nature? I saw in Canada, they can prescribe, trips to nature or Reiki or spiritual or some other kinds of practices. So I do appreciate, and that was what I said to Suzanne in the beginning, you might not be happy that I'm leading a session called Renaming Mental Health when I'm not sure that renaming mental health itself is really where we start. So
I want to bring just a little bit of context too, because I think some of the things that we're talking about, and to Lisa's point, are happening in other sessions.
Yeah.
So those points were not lost, right?
Yeah.
So we have another conversation that's happening right now about about those care providers. How do we take this and integrate it into care? So that's a whole conversation that's going, because we do recognize that that's a thing. And I hope that the conversation here, like if we use these different terms, does that break down the barriers so that when we implement those policies and procedures that we figure out in the conversation that's happening virtually next door, that those patients and those caregivers are willing to say those words that break down the barriers, that Kiana faced, right? Or that many of us face. And so those conversations are definitely happening next door. So I want you to know that. And then also I want you to remove the idea that cost matters. Cost doesn't matter. Blue sky this thing. It's a blue sky idea. And one of the things I love most about Livestrong is we're going to take this content and we're going to see what we can do to make this a reality. So I want to hear the big blue sky and let me figure out how to fund it. because I love my job. I love asking for money, so no. But yeah, you know, what can we, I love the idea of resiliency. Vital Hearts, one of the women leading another one of the sessions, calls it resiliency, and they do a training around PTSD for cancer care providers, for those who are on the front lines of providing cancer care and are losing patients every day. What is that like for them mentally? And can they, you know, how do they recover? So yeah, I love that idea of resiliency, and would certainly love to hear what else we can think of and how we could approach it, even if we don't name it. What is the maybe it's what is the conversation like to start to have?
I can't see all the screens.
Alternate terminology. What could that be? Hillary.
Hi, these are thoughts not fully formed, but these are just more or less reactions to things that have been said. I work with an organization that works with kids who have cancer. And I know, and they know, that language is loaded. It has all kinds of connotation. It has all kinds of long-standing effect on these children. Our kids are by nature and by immunological realities, they're isolated, and they may present with mental health behaviors. But if we label that, if we use that label follows them throughout their lives. So even though it may not be the easiest thing to change that label, I think it's well worth the effort, because these are labels that follow kids into young adulthood, into adulthood. And what is really probably the most logical behavior, given their experience of disease and isolation, is now labeled as something entirely different, with huge onus on it. So yeah, I don't know if that sounds congruent or not, but I think that it is a subject well worth addressing.
Thank you, Hillary. I think you're speaking to that sort of pathologizing nature that we've had to very normative responses. Of course, if you're a kid with cancer and you're isolated and you can't play and you're not allowed to access the developmental milestones that all of your peers are, of course you might be withdrawn or sad or angry or demonstrating all kinds of reactions. So how do we help build either emotional intelligence, emotional agility and resilience in kids, in parents, in caregivers, et cetera, so that we aren't doubling down on the harm that we're causing people. So not only are you harmed because you have to go through cancer treatment, but now we're sort of putting you further in a corner because we're naming your normative reactions as not normal. So I wonder about agility and resiliency around well-being, and really focusing on our whole well-being and helping people reframe that their responses might actually be like, what a great response you had, what capacity you showed in the face of crazy circumstances. Like, how might we flip the script to make people's, reactions more, help them see them as ways of really surviving and resiliency as opposed to pathology.
Scott, you've got your hand raised.
I do. Excuse me. Yeah, I had been thinking before the session that what I looked for was emotional resilience. So hearing Michael bring that up several times was reinforcing for me. I've always looked to Livestrong as a great example of resilience, the things that our organization stands for. And I think it's really important for cancer survivors and caregivers to hear that message, and for us to provide ways for things to do for cancer survivors and caregivers to do that build emotional resilience, the same way that Livestrong at the Y would have resistance training for physical needs. If we have resilience training for emotional needs, I think that's really helpful. Not necessarily counseling so much as resilience training.
And I think we have to expand to what Kiana said, to what you just said too, is like, what does that training look like more broadly, and not just being a specific kind of going to see a psychotherapist or going to see a psychiatrist. I see some more hands up.
Yeah.
Suzanne?
Claire.
Hi, thank you. I'm Claire from Cancer Support Community Montana. I just wanted to add, with the renaming, I know there is the stigma of mental health and behavioral health. One thing we try to incorporate here at CSC is being an advocate for cancer survivors and patients in the healthcare system, and incorporating psychosocial support. And I know we probably can't call it psychosocial health. That brings to mind the Christian Bale movie for me, but just incorporating full life, kind of like Michael was saying, having a pet, having relationships at home, things like that, and incorporating all of that. We're at a time of great change in America because of COVID and working from home. I'm hearing from a lot of people that working from home is a mental health respite for them, and that's helpful. So I think now more than ever, we have to be willing to change and to look at what people need and want and be willing to compromise with them on that.
Absolutely. Jordan.
Hi, I work with Living Proof Exhibit. We're in Illinois and Iowa, and we offer like art sessions to people touched by cancer. And one thing, it was brought up in my head when we were talking about like the pathology of language. For our sessions, we can't call it art therapy, even though that's kind of what it is. And we are equipped. Sometimes we have like social workers and nurses at our sessions, but when patients or survivors come to our sessions, they don't want to hear that they're coming to a therapy session. They just want a basic art class. And so if that helps us kind of, narrow things down as we're talking about the language that we use. I just thought that might help a little bit.
Yeah, I really appreciate that. That idea too, that creativity, by the way, is a way that we can process our stress and our all of the very normative responses we're having to a very abnormal situation.
Suzanne, you've got your hand up.
Yes, thank you. My comment is a little more general. I like some of the ideas that are coming up, and just sort of cautionary is that as long as the term is not something that is so euphemistic that it prevents access, because I think that, just the terms mental health, people feel if I go to access something, what does that say about me? We don't want to disguise it so much that people don't know what it is and won't access it. And also, thinking about the different populations, what's translatable, what would make sense in other cultures, other languages.
I love that. Thank you.
Mara.
Hi there. I work with kids in art, and we provide art experiences for kids in waiting rooms and in hospital. And of course, during COVID, we've been virtual. But what we find is it's not so much mental health as the isolation and anxiety is the biggest issues that these kids are facing. And so the community building aspect has become really huge for us, connecting kids to kids, connecting parents to parents. And I like the whole resiliency idea. I think that's what we're building by providing community. So I don't know how to fit those words in, but I know that the kids are not looking for words. They're looking for experiences and just sharing, being together. It's been definitely a journey, but it's amazing what comes out during these. And we don't call them therapy sessions, we call them workshops. And
Yeah.
It's a therapy of sort. All art is a therapy of it's just innate in art. So that's what we're looking at.
I love that idea of resilience, but also about community building. The word belonging keeps coming back over and over again in my head. I think about the work of belonging by people like John Powell, who works at the Othering Belonging Institute in Berkeley, but others, like really at our very core, we feel this draw to feel a sense of belonging. And often what happens as we navigate cancer care systems, whether we're the patient or the caregiver, is that we feel an isolation and a lack of belonging because we are othered. And so I wonder how, however we label this, we make people feel that they can come back into a place of belonging, whatever that looks like.
Tracy, you've got your hand up.
Hi, yeah, I just wanted to give my 2 cents. I'm Tracy over at Livestrong. And one word that really comes to mind for me, because I've heard it referenced in my mental health circle, is vibrant health. because it doesn't just limit you to mental health. It also combines your inner core, your health, your physical health, combined with your mental health. So I just wanted to give my 2 cents that, you know, vibrant health really speaks to me because I feel like it combines the two.
It's certainly aspirational for sure.
Cindy.
Hi, I'm Cindy Feist, and I'm from Salisbury, Maryland, and we are on the lower eastern shore of Salisbury, Delaware, Maryland, Virginia is where we're located. And it's a very small area, very local, and those people that hear mental health, it is a stigma, especially here, because everybody knows everybody. What I do is I'm an executive director with Women Supporting Women, which is a small nonprofit breast cancer organization. And what I've been looking at recently is to try to incorporate that mental health piece of it, but not saying, again, mental health, because it's taboo around here. So what I actually was looking at was pulling a new program that we were putting in place called Forward Focus. So that way they could actually look ahead of their disease, see something beyond the disease and go from there. So I don't know if that could be incorporated into it or not, but that's just where I was trying to put another spin on it.
Thank you.
Brenna. Yeah, I love that. Brenna.
Thank you. Just to I'll try to get my hand down here.
I'll get it.
Piggyback off of Cindy's. We are working, Brenna Finnerty, work for John Stoddard Cancer Center in Des Moines, Iowa. So I know there was another Iowan, Jordan, I think had mentioned that, or is it at least Midwesterner. One of the things to piggyback off of Cindy's, we are doing with kind of that forward focus is working on being proactive with care and instituting the clinical name as a patient-guided support clinic. We're trying to rename it so that it also translates better to some of the conversations, but it's an integrative certified oncology nurse who's going through a fellowship in integrative oncology. And essentially she's a one-stop shop. And so a referral from our care teams would go to her and she will say, hey, let's get ahead of this treatment by looking at this physical therapy course. These are our What's on Your Mind, which is our free mental health counseling program. They're just going to talk to you about some of the things that might come up, your feelings or emotions and coping strategies. Here's our nutrition. So really it's incorporated into that holistic care model so that it's just another referral. It's just a service. And so we are supporting you nutritionally, your physical body, prescribing movement, and it's just part of that package of care. I think to that point, looking forward, and are hoping also that'll help from a referral standpoint, because I think as we've been listening, right, providers a lot of times are making these referrals. That's the person they're going to, or their navigator. And even saying, we have the What's on Your Mind program, which we tried to take away kind of that counseling, therapy, a lot of the words. It's still seen as a separate service. Oh, I need this mental health care service. Whereas now we refer everyone to this, our patient-centered support guidance, and she's going to talk you through a lot of programs that'll be, catered towards you. So we're hoping that will also help. But I like the idea of thinking forward and wrapping that into kind of the holistic care model.
Thank you, Brianna. And one of the things you just touched on there was kind of whether there's the name or not, if it's not a part of the everyday practices and the culture and the institutions and the policies, it doesn't really matter what we name it. And it's very rare that a patient will say, if they say you have to go do this treatment, that we necessarily question it. So if it comes through because of the belief and the practices of the care providers. I wanted to jump in. I know we have some other raised hands, but Kiana asked a really good question, which I wanted to, if you didn't see it in the chat, I wanted to bring it back into the room, which is, what are our goals for the new language? Is it to challenge stigma or to help people value mental, emotional, social well-being? So I think just as a reminder of how we frame even thinking about this conversation. Thank you.
And I just wanted to add a note to that when thinking about this of I started to type this in the chat of how, some communities and individuals who are, let it be experiencing cancer or supporting people who are experiencing cancer, already were living with various mental health dynamics. I call them mental health landscapes or inner landscapes. And so some of the narratives I've heard before where it's like only thinking of your future doesn't necessarily apply to folks where, well, if I already had depression or if I was already living with anxiety as something that is a part of my landscape of health that I have to manage for the rest of my life, how do we apply getting support, let it be policies and practices and programs that can help a patient when that the experience of cancer is compounding your mental health landscape. And that's why not saying the words mental health or not trying to challenge the stigma can still be very isolating for folks. And so I just wanted to put that perspective out there of like, not everyone, a lot of people have mental health dynamics that they're already living with and they will live with for most of their life, if not all of it. And so how do we make sure we're accounting for that too, opposed to episodic mental health challenges or issues?
Yeah, that are, again, normative responses to, maybe a really abnormal situation like a cancer diagnosis or some other emergency. I appreciate that. Other folks have things that you want to weigh in, and I just want to name out loud, as somebody who sometimes likes to have things wrapped up, I just want to open that part of our goal for this conversation was to not have it neatly wrapped up, but to really examine and pull apart lots of different perspectives. But if you're like me and you're kind of feeling anxious, like, do we have 10 minutes until we have a plan? We don't have to walk away with a plan. The purpose was to invite your minds to this table to create some rich conversations for us to think about where we go from here.
I would love to offer up, yes, thank you, Lisa. I am excited about a lot of the words that we're using here and a lot of the thoughts that we have and how we'll be able to tie this back together to some of the other conversations. Yeah. I wanted to bring up some words that I will owe to Michael for sure, and to some of the words we've heard here that I've been furiously taking notes. Well-being, comprehensive. So because I'm thinking holistically about the process, right, that Lisa has mentioned a lot, and we've all talked about the idea of planning and that idea of future that you guys, have brought up around this future thing. So planning to me feels easy, relatable, a word that's translatable to all of your points. Anyway, I had written down comprehensive well-being planning, or a comprehensive well-being plan, to kind of Tracy's idea of vibrant health, or and that future planning, and Michael's word of comprehensive that I really love, or systemic was another one. But I'd love for you to continue to, let's throw out ideas or words or thoughts that I can furiously take notes on, and we can move on.
I love emotional nutrition. What if we did that? To take from Michael, because I think that helps. I personally worry a little bit about too much future think, because sometimes people need to just be addressing what they're experiencing in this moment. And if we think about, we would never criticize ourselves for investing in healthy food for our nutrition. And what if we thought about emotional nutrition? Michael's got his hands up.
Yep. All right, Michael, go for it.
I just had another adjacent idea, which is that the world has been very meticulously mapped and documented, but we have a much blurrier impression of the universe around us. And I think everybody understands that, their mood is subject to change more frequently than the weather. But when you're entering cancer treatment, you don't just treat the patient, you treat the family. You have to create an opportunistic series or set of circumstances that will steward success. And there are often, whether it's on account of finance, geography, availability of care, access to specialists, there are impediments to having a speedy or longitudinally successful treatment. What I'm wondering about is, I don't think that anybody, with the possible exception of yours truly, because I've had a lifelong struggle very publicly with mental health, and I only completed this exercise recently of actually mapping all those moments over a 30-year timeline. If you go to a nutritionist, you map and monitor your food intake, typically over the course of 7 to 14 days. I don't know that anybody in a hospital setting or even in an outpatient facility ever goes through to identify potential stumbling blocks, areas of vulnerability, periods that constitute precedent. You know, this is what the CIA would do if you're undergoing a comprehensive, if they're scrutinizing you for readiness for the human intelligence, but they're not going to do it for an average desk jockey, right? They don't care. I don't know why we're not, you know, in the same way that you'd have blood drawn if you're going to undergo chemo, the same way that you might have an EEG if you're dealing with a glioblastoma. I wonder if, you know, a Xerox isn't a copy machine, a Xerox is a Xerox. Nike isn't just a shoe brand, Nike is a Nike. Is there a way that Livestrong could actually own a bigger piece of this? Because from my memory, warped though it may be, I seem to recall that Strava's success early and Livestrong's success early were sort of in the same gravitational universe. And I'm wondering, I mean, since you guys certainly have the brand permission and sanction to venture into this field, even if you just made one of these, you know, mood mapping tools more routinely available, the same way that Pitch is a vastly better product than Google Slides, and Google Slides was a vastly better product than PowerPoint. Maybe just putting the tool into people's hands so they can outfit their caregiver with a higher fidelity, higher resolution sense of areas of vulnerability as they embark upon care.
I love that expression, areas of vulnerability, and also this idea of mood mapping. Thank you. That's, my late husband was a geographer, and he used GIS systems to help map, you know, information and systems. And I think being able to help both the patient and the caregiver and the doctors sort of have a more bird's eye view of what's happening, except for those, you know, few points of contact in the facility, could be really helpful. And I love the idea of using technology. Wellness landscape, Kiana said, yeah. I think that landscape and mapping and helping us, again, is another way to see the whole person, and not just the person, but the, as you were saying, the sort of other planets that are in the solar system, like the care providers, et cetera. Yeah. Other folks want to either piggyback off what Michael shared or have your own sort of insights or questions. It doesn't have to be answers. It can be more curiosities.
Danielle, I saw you wave your hand a little bit ago. Do you want to share?
Hey there. Yes, Denver Health is an anchor institution. So as a partner in the community, we address social, emotional, and physical well-being amidst our hospital, clinics, etc. And yet I was approached by the breast health team to really identify partners that approach mental health in this capacity. Although we speak to all of our patients and community members addressing this whole person care model, we are still approached with stigma. We treat 90% of Colorado's Medicare and Medicaid uninsured patients. So breaking down that stigma, not only with the individual, but within their communities, is something that we're still grasping. And I love to hear the different feedback from different people on this group to really identify how we further that and break down that stigma while approaching the whole person care.
Yeah, yeah. Thank you. Thanks for the work you do, and thank you for inviting us to keep this conversation going. Yeah. Other folks, I can't see the whole screen, so I'm sorry if you're raising your hand, but I think Suzanne's on it.
I know Hillary had something to say a little bit ago. Do you still want to share?
Sure. I was just actually chatting with Michael. I think your insights are amazing, and I love the idea of digital nutrition and that being a real contributor to resilience. I think it's terrific. I work for Kids Kicking Cancer, which is an organization which has recently adopted two initiatives, the Childhood Resilience Initiative and the Adult Resilient Initiative. Resilience is what it's all about. The obstacles are there, especially with kids who have cancer or adults who have cancer and different issues. Isolation is the enemy. And if we can, it really is. And it's a war. And we fight this isolation all the time. My colleague Amanda, on part of the screen, will corroborate when I say we have done hundreds and hundreds of Zooms with parent groups and with children's groups and with opioid groups. We have done everything we can to make sure that people are not isolated. And I don't know if that's exactly germane to the concept of language, which is very important to me personally, but I think it's part of the entire circle. And I think that, I don't know what else to say other than I'm very grateful to be participating in this session. I think it's tremendously informative, and it really underlines the importance of what we all do. So thank you.
Thank you. You know, something to carry on or piggyback with Michael's idea around mapping and mood mapping is the other thing that maps do for us sort of physically and, you know, emotionally, psychologically is they help us see our location in a bigger context, in a bigger world. And sometimes mental health landscapes that we face, whether it's related to our cancer diagnosis or possibly an impending death or the death of a loved one, is we feel like we can only see our particular, you know, location on the map. And this aspect of helping us map further beyond our singular location or our family's location might help to break down in some ways, for instance, the sort of toxicity of isolation that you were talking about, Hillary, and also help us think about how we ground and see that there's actually paths to different accesses or different communities of care that might be more accessible. And if we don't actually kind of see it in the context of a map, we may stay in our singular isolation. So you can tell I'm all for the mapping analogy. So I'm thinking about that and how we move forward. Other folks?
Yeah, Suzanne.
I also like that in a map, you use it to go from one place to another. So there's movement, you're not stuck.
Yeah, love that, yeah.
In one of our sister sessions that's happening, they're talking about connecting, right? Connecting to people like me or people who have been on that, perhaps on that place on the map, right? And I love that idea of, you know, Michael calling it topography, right? The idea that it is, this is where I am today. And then in this other conversation, we're learning, how do I get there? How do I get to where you are? How did you get there? That would be tremendous from an emotional well-being standpoint, I think.
I also think inviting people to look at their own map over time, sort of where they've been in different stages of their own journey, whether as a patient or care provider, also helps us not get stuck in the story that I always feel this way. When we look back across the map, when we think about the emotional map of our own journey, and we can look back at a time where we see, oh, but there were these other times that I've been tracking across where I had moments of joy, or I had moments of hope, or I struggled in this way, not always joyful things. But mapping allows us to not, again, to see not just future possibility, how do I get there to that point, but also actually I'm not, even though it feels like I've always felt this way and I'm always going to feel this way, when I can look at the map of where I've been, it helps us understand that there's always movement happening, even when we don't feel it in that moment. Yeah, Scott contributed, liked the idea of finding joy. And I would say that that's part of a prescription that I would love for us to think about, is how we find moments of joy, even in the face of adversity. Other folks want to chime in? We have till, Suzanne reminded me we had till 12:30. I thought we had to be done at 12. I'm so excited, Central Time anyway. So please, folks, chime in. Again, carrying this forward to something new. Cameron's.
Go for it, Cameron.
Yeah.
Yeah, you said joy, and that is the moniker of where I work at Children's Cancer Association. We're all about joy, finding joy, prescribing joy, and I work in the capacity as a music specialist. So at Dornbecker up at OHSU, I'm the guitar guy on the oncology hematology unit, and I really find, like, while we're not performing therapy or music therapy, we are striving to find those moments of joy. And this conversation really piqued my interest, being like, while watching children go through something so traumatic and so life-changing and at times life-ending, I found that the families that I've worked with, there's two categories where it's like there's survivors and there's those who are survived by. And I think that we've talked about the stigma of mental health and that name, and how like where is the support for the survivor after they've completed and defeated cancer? Where's the support for the family after their child has passed on? And it's like something that it's I hate that aspect of my work and the friends I've made and lost, but I'm really interested in a lot of the words of like vibrant health, and just I feel like when the term mental health is thrown around, I feel like it escapes away. Like I like a lot of the analogies we're using, and I guess like an asteroid kind of like leaving our solar system, you know, where it's like we really need to lasso that thing and bring it back, because it's well-being, it's health, you know, and however close we can bring mental health just being synonymous with health, I think is when these kids who turn into adults can get proper care, where therapy can be more commonplace. And yeah, I guess the I really love this conversation, and I think a lot about a lot of those patients who, you know, after the fact, it's like what they've accomplished after surviving is like such an amazing feat, but the work's not done, and it's never done.
Yeah, I appreciate you bringing that up, Cameron. First of all, I love the idea of music on an oncology ward with kids. I want to know more about that for sure. But also the idea that we have to think about not just this mapping as happening just at the institutional level when we're in contact, and how do we actually help broaden this beyond maybe a point of one single point of care, whether it's survivorship or something else. I certainly see families in my work at Reimaging Grief who've lost their loved ones and they're dealing with grief in the aftermath. But I also work directly with cancer patients to process their own anticipatory grief. So I think we have to think beyond just kind of the singular engagements of points of care, but also just not just beyond in the map or the topography of that person's family, but also in the longitudinal thinking about sort of before and middle and whatever the after time is for the family and for the patients. Yeah. Thanks, you guys. Other thoughts about naming and language, or about how we expand even what perhaps services or interventions, or even what you think might be the barriers for the institutions themselves to bring in this sort of newly visioned way that we're thinking about this kind of care. So like, how would this mapping idea and technology interface, or what are the possibilities there when we think about interfacing with institutions?
Big, scary question.
Or whatever you want to say. Yeah, I'm just throwing out new ideas, but you get to just say whatever is on your mind.
Scott, I would love to. I'm gonna throw a rock at you. Scott is he connects to Livestrong and cancer in lots of ways. He's a board member. He's a cancer survivor. He was a cancer caregiver, and also lost his wife to cancer. He has seen this disease on every front actually possible, I believe. And he's a volunteer. He's a fundraiser. He's in everything. And so, Scott, I would love to hear kind of your feedback on everything that we've kind of talked about, especially that topography idea, because you've seen it from so many spaces. And as a parent, you know, with kids who've had to deal with this grief, what are your thoughts on this?
There's the hardest part, is the understanding what to do for your kids. I guess the one thing I would add that I keep thinking about, and I haven't been sure how to put it into words yet, I'm still not, is something that came up about forward focus, and how, while I think that is really important, I also worry about it, because every time I think about forward, I feel like I'm being asked to give up past, which I'm not ever prepared to do. So that's something I will always carry with me and build on, even as I look for ways to find new joy and move forward. So that's just something to be aware of, is the importance of the history, which is kind of what I like about the mapping idea, being able to see where I've been as I'm thinking about where I'll go.
I think that's, I love that, Scott. I think it's so important. You know, in the grief world, of course, there's a lot of stigma around. You just need to get over it and move on.
Right.
And we also live, back to my cultural references. Sorry, I can never escape my cultural narrative therapy training. We live in a pretty toxic, you know, positivity toxic world. And so I think, not that I don't think forward or moments of joy aren't important. I think it's an and.
Yeah.
And I think we have to find a way to make it more integrative, to sort of name and honor what was while we think about what will be, and how do we carry forward the values that we have, the experiences that we've had, the qualities that we admire into whatever this future visioning is. So I think it's an and I agree with you, Scott. I think that mapping analogy allows us to not have to choose, you know, to completely gaze ourselves forward or be gazing in the past. We get to sort of see the terrain that we've traveled.
Yeah, 100%.
And also, when we get to look at the terrain that we've traveled, when we think about this metaphor of, I'm a metaphor junkie, when we think about this metaphor of mapping, we get to, again, notice all of our resiliencies and our capacities. I remember when I didn't think that I was going to make over that mountain, which that mountain might have been your last chemo or your whatever. And now I can look back in that map and be like, not only did I make it over that mountain, I went out the next day and, I don't know, whatever, had a moment of joy. So I think it's really important for us to build our resiliency and to integrate all of our experiences by being able to see where we've been, as much as focusing on where we're going. Yeah. Thank you. Thanks, Scott. You guys can tell I get a little excited about these conversations. I'm really passionate about this.
Yeah, this is exactly why, this is what we do at Livestrong. Like, this is, again, what is so exciting. It's listening and hearing from all of these points of view, because that's why I love about ICON and this solution session, because we're able to take these points of view that we otherwise might not consider, or that we might forget, because because of a bias that we don't realize we have, because of our filters, because of our own experience. And so, Scott, thank you for being brave enough to speak when I put you on the spot like that. Thank you for sharing. Tracy.
Yeah, just to piggyback on the joy concept, for me, joy is versus happiness. I mean, it's a choice, and I think in a journey. So that's why I really like the connection with the joy and the vibrant living health aspects of this. So I just wanted to piggyback on that, and you know, I think it's important to realize there's a big difference between joy and finding happiness.
Yeah. I love that. And I think we find joy when we sit in sort of a revelatory manner about the things that we value and the things that we celebrate. And sometimes when we're busy in the tactical, practical logistics of cancer care, it's very, very easy to forget about how we sort of sit and revel at the little moments of joy, the things that light us up, maybe music as an example. And how do we integrate that so that we can keep sparks of joy along our journey, along our travel? I love that. Other insights or inputs? I want to offer some quiet here, even if as people noodle. I know not everybody's always happy to unmute their mic and get on screen, but would love to hear from folks. Now, I won't call on anybody. I'm not going to pull a Suzanne and call on anybody. But if there's somebody who hasn't contributed yet, and you just remember, you don't have to have a fully formed answer. You can even just have a question. We'd love to make sure we're hearing, you know, all the voices.
So I'm going to be bold because one voice we haven't.
It wasn't me. It was her.
Yeah, it was totally me. I'm gonna ask Amanda, and the reason I'm asking Amanda is because just looking at you, I'm guessing you're younger than I am, and in the spirit of trying to be inclusive, I would love to hear your point of view. Why did you join the conversation, and what is your feedback on what we've had to say?
Okay, so I work with Hillary at Kids Kicking Cancer. I am, I guess, younger than most of you on the call. I actually kind of had a question, if that's all right.
Yeah.
So, I mean, I guess I kind of wanted to hear from everyone what they thought was their best way to kind of create that inclusive environment and to create that kind of normalcy. Because on the one hand, if we create these like groups within different survivors, that helps them kind of feel more normal. But on the other hand, does that at the same time risk kind of perpetuating that insularity, whereas we're trying to create a sense of normalcy from a broader perspective?
It's a great question. How do you at once make somebody feel like they are part of a community of other people and not isolated, and not pin them to their singular identity as a survivor or as a active cancer patient? There's a real duality in that challenge for sure. Thank you, Amanda. Great question. Folks want to chime in on what they've seen work or what they think?
Claire.
I think that's a great question, Amanda. I had a participant once say, you know, I never wanted to be part of the cancer club, and no one does. So I think that's a really important thing to consider all throughout the journey of cancer, from diagnosis to beyond. And we try to incorporate programs. It's called Take Charge, and it's about life after cancer, when people stop bringing you casseroles and stop asking how you're doing. And I guess ideally, in creating a community for people undergoing cancer, ideally, you know, they take the same journey afterwards and move on to survivorship with those new friends that they've made. And that's not always the case. But yeah, that is something to consider every day, because you don't want the self-perpetuating cycle. So I'm open to ideas too.
I think we can be, and I'm a big, anybody who listens to my podcast or follows me knows, like, and actually I have a bracelet with an ampersand. That's how much I believe in that word. And I think we can do and. I'd be curious to think about how systems of care help people feel seen in their identity as a cancer patient or as a cancer survivor, but also use language to help people go back to your joy conversation many of you brought up, which is, besides being in cancer, you know, what brings you joy? I'm a musician, I'm a whatever, I'm a brother, a big brother, I'm a whatever it is. So how do we do that duality? How do we help people reconnect to our multiple identities? Because we walk through life with multiple identities. Some of them we may not be able to do because of the physical limitations of our cancer, for instance, you know, but how do we help people feel grounded in their multiple identities as they navigate through this care? And that goes both for the patient, I would say, and for the caregivers and the legacy that's left for the caregivers. I definitely never thought I was going to be in the Widows Club, and I really don't like being in the Widows Club. And what I've learned over these last 10 years is that I'm also in lots of other clubs, and those clubs bring me as much value in my identity as does being in the Widow Club does. Yeah.
That maybe we had a patient family. Oh, sorry.
No, I was calling on you. Yeah.
Like, we had a patient family, and he unfortunately passed away when he was 26, but she said, as they had moved through different treatments, the mother started bringing pictures. He was a huge rock climber, active cyclist, traveled constantly, and she blew them up and would bring them and put them in his room when he was inpatient, because she's like, I didn't want the next new doctor, as we're going through, to be like, oh, all I see of you is the snapshot in time. I wanted them to be like, gosh, this kid used to do this and this and this. And they had a very visual reminder every time they came into his room. And I just thought that was the coolest thing. And their family's just amazing and doing really, really great things. But it is true that, and then we see it from the clinician standpoint that when they're seeing X amount of patients per day, that is all they have, right? And so, and how are we getting them additional information, or if it's the first time they're meeting? But I think that might even just be an easy way for us too, from the healthcare standpoint. But I thought that was a really, really neat idea from a patient family.
Well, what you're talking about is the patient family reminding the clinicians and the practitioners that we are whole persons, and that we are persons beyond our disease and beyond whatever it is that singular identity that we're showing. And it took a family to do that, to help the physician see, so that they might address the family differently. But what if we had a system including by the language that we have, that we required physicians, caregivers, everybody to see the whole person. So I love that. What a great creative strategy. Scott?
Yeah, this is bringing back a memory from all of the conversation about mapping and the conversation about the many things that we each are. When I was hospitalized, my son had created a map of my dad, which was a picture of me with all of the various things that I had always been involved with, from Livestrong to music to everything else, hanging on my hospital wall. It's just, it's a good memory.
Thank you, Scott. This mapping idea, this mapping and helping us ourselves see our whole identities and our whole selves. I love that. I really love that.
Jordan.
I wonder, I don't know how it would work with, you know, getting physicians on board and stuff, because that's not something I specialize in. But, you know, if they had an active role in creating these maps, or like encourage their patients to create these maps, would that help them, both sides, to see their patient to see themselves and the physician to see the patient as, you know, this, like a multitude of beings within one being? You know, there's not just one label there.
Yeah.
And so that would kind of humanize a patient for a physician. I just going off that mapping and the encouragement with mapping.
I think so. And not only will it help humanize, but it might help them see a kind of resilience, an aspect or quality of resilience that patient had that they didn't know about until they knew about that whole version of that person. Michael, do you want to chime in?
Yeah, there's only one gravely underserved community that we've neglected to address, which is clinicians and caregivers.
Yeah.
They're among the least equipped for the hardships triggered or aggravated by COVID. They are leaving the profession in increasing numbers. And one of the ways to secure buy-in is, and there are a lot of people who specialize in this, not me, obviously, but who think about the continuum of care for physicians, not just the patients, because they're experiencing extraordinary hardship. And it's not a solution to say you're going to be 36 hours on, 12 off, 36 on, 12 off. And pretending as though you're inured to it, like you're of English descent and can maintain a stiff upper lip, is not an answer either. And so one of the paths to entry, or maybe the least intimidating barrier here, could be through the caregivers themselves, is some sort of a curriculum or some sort of a requirement, or even just some sort of a tool that can help them better deal with the hardships of the job now. And I can't think of anybody with a larger profile than Livestrong to help them do it. But these organizations are incredibly political. This culture is almost immune to cultural innovation. They're willing to use the latest tools and techniques unless or until it concerns the people administering those tools and techniques.
Yeah.
And so you might actually be able to reach a vastly larger number of people by targeting physicians and clinicians first, and assuming that through them they can reach their patients.
I absolutely love that. And I've actually had the honor of working with some of the practitioners at the Livestrong Cancer Institutes to do just that, to help break down some of like, what do the helpers need themselves? And until you can experience being helped and shift your own ideas around about what wellness means and about accessing health, you're never going to actually be the advocate or the provider of those services to other people. First of all, because you're going to have, your tank will be empty, but also because you won't be able to speak to at an experiential level, what did it feel like and what did I gain from accessing that help? And it's one thing to talk the talk, but if a provider can show up and walk the walk because they have had that lived experience of seeking help, of being held in community, of honoring the pain and the trauma that they witnessed, etc., they're much more incredible providers. And it's not just medical providers. I was trained as a social worker, and we talked a lot about self-care and self-help, and there was nothing at the institutional level that encouraged us to do that. And so many of us in the social work community have a lot of burnout from that. So I think your point, Michael, is really spot on, that one place to start with some of this kind of mapping concept around this wellness is with the providers themselves, because we know they're going to have the biggest impact in lifting a barrier that might be there. Yeah, I love that.
I mentioned the partner that we work with now, Vital Hearts, that does that work out of Denver. And I think that could be a great opportunity for us to collaborate and partner together, and this idea of mapping, and maybe that's where we start